My name is Jeremy Shuman. I'm a licensed psychologist in St. Louis, Missouri. I work at the Center for Mindfulness and CBT, where I'm clinical director, and I have a small training program. I teach a seminar. I'm involved with the ICBT dissemination efforts, and I'm a consultant there. I also have my own caseload where I do a lot of ERP and a lot of ICBT. I would say a little more than half of my client load has OCD. And I also see a lot of people who are professionals, doctors and lawyers and academics and that kind of stuff as a secondary niche. And of the folks I have with OCD, more recently, what I've been doing is taking the treatment-resistant cases from my community. So I live in St. Louis, where the amazing Alec Pollard has developed this wonderful clinic, St. Louis Behavioral Medicine. They have an IOP and a partial hospitalization program, but people drop out of that and then they call me. And often they had a more complex presentation that needed a second eye on, maybe needed an alternative approach because really high quality exposure and response prevention was not giving people the results that they needed in these cases. More and more, my caseload has trended towards folks who have OCD but are also autistic or also have another co-occurring condition in the neurodiversity realm that makes treatment a little bit more complicated. This work comes out of my passion for listening to people and just trying to be honest. I feel like I've had so much training in the behavioral model that I've gone into a lot of cases where I say, this is how it's supposed to be. This is going to be what happens. And then the client comes back and says, I felt a little different. This part was working. This part didn't work. And earlier on in my training, the only answer I would have to that is, let's try to reduce your compulsions more. You're still white knuckling or something like that. And over time, I dropped that language. I could see if people were putting in the effort, I could troubleshoot it with them. And there was this subjective experience of what it was like to have OCD that was not fully encompassed within the model of just treating the negative reinforcement loop through ERP alone. Even when bringing ICBT into my practice and taking a different approach in conceptualizing and treating, I still found that these forms of neurodiversity were really valuable to talk about in understanding the narrative behind why would I do a compulsion? Well, there's a rationale, and little bits of confusion creep into this narrative when someone's lived experience is atypical for what their community is, and they get invalidated about that. So hearing these stories over and over again, I got fired up about it as I get fired up about things. Further, while this thought was percolating in my brain, I was also doing some advocacy work about the intersection of OCD and autism and trying to conceptualize cases a little bit more bespoke, a little bit more with some wisdom to it, as opposed to just thinking in the most bare bones, contentless behavioral terms. I've really found that bringing in the interplay of how common experiences that autistic people have had into how they rationalize their compulsions to be extremely valuable in that work. So I tried to make some presentations for the IOCDF conference this year. Unfortunately, I didn't get those talks accepted, but maybe next year I got some good partnerships, try to get onto some panels about differential functional assessment between OCD and autism next year. But for this year, they gave me the support group on OCD as neurodivergence, which this idea had been bouncing around in my head for a while. And so I built it out, and the support group went pretty well. I was really happy with the feedback I got. And so I left that conference just really fired up about trying to express some of this material. And I have some dreams for it. I have some dreams of what might be able to happen and some more concrete plans of things we can do in the meanwhile that I hope bring this information forward. So my hope is that as we talk about this material, just little kernels of information are going to creep into your brain. Maybe some things that you already know and that you say, this is already what I'm doing, but maybe I give you permission to speak that part out loud a little bit more, or to be confident in what you know and say it to others, so that we see some of this language creep into the discourse about OCD and not just get from the top down the most bare bones version, and then people with a lot of knowledge and lived experience feeling very timid to speak up about things that they know. It can feel like I don't have a place to do that. I know people with OCD often go years and years with really bad treatment, or they're poorly diagnosed. I don't want to give anything other than what is absolutely best for those people. But by having only discourse about first line treatment and non-complex cases, we do a disservice to all of these really complex cases and people who do not benefit so much from first line treatment. So I'm hopeful that as this information creeps in, you're going to say, I got something to say about this too, and you're going to start saying it. That's what I want to see out of all this. So format, I'm going to talk for a long time because I like to talk for a long time. 2 hours is a lot to sit and listen to someone. Feel free to turn your camera off. Feel free to go for a walk. Feel free to watch this on video. This is being recorded. It'll be on my YouTube channel. That's not going to bother me. I'm autistic. I like to info dump. I like to say a lot of stuff. I made 22 slides for an hour-long talk. Or for a 2-hour talk. I'm going to fill the whole 2 hours with that. And it's hard for me getting distracted. If I pull off onto a tangent, I will miss the stuff that I want to say. So we're going to start just with some definitions here. I guess we should really start with, does anyone know what happened on this day 33 years ago? I know that someone in this room did because she posted it on Facebook and I'm directly stealing it from her. This is the 33-year anniversary of passing of the Americans with Disabilities Act. Says everyone should be able to have access to things that should be in a public space. And it's a really nice reminder of what it is that we're trying to do here. The Americans with Disability Act serves to increase inclusivity, but we actually find a lot of benefit that happens to everybody when we make the world more accommodating and more accessible. And the same thing is going to happen when we bring in neurodiversity-affirming treatment into the mental health world. What's going to be helpful for folks who felt marginalized and excluded is still going to be good, helpful stuff for folks who fit right in the mainstream of where treatment is oriented. Okay, so some terms here. Neurodiversity, that's just a recognition that there are a lot of neurological traits that compose our cognition and processing. And there's a diversity of how these traits are expressed amongst our population. And there's a lot of difference in a bunch of different ways. The neurodiversity movement came out of a disability rights movement, and there's lots of people who like to lay claim to that title. I'm not going to try to make a history lesson out of it, but the neurodiversity movement, maybe we could look at it as most originating out of work with the autistic community, and recognizing that the descriptions of autism were complaints that people have about autistic people's behavior. And the autistic community said, we would like to say, what are the subjective experiences that lead us to do these observable behaviors that other people start complaining about? Maybe with that understanding, we would build more acceptance. Maybe we'll also change our treatment strategies based off of more accurate conceptualization. I'm trying to take lessons that came out of that process and apply them to the OCD world. So if neurodiversity applies to a group, because a group can be diverse, an individual can't be diverse, and it's just one person. An individual can be divergent, though. And so now we have this word neurodivergent. And there's probably two different ways that we can apply this. There are divergent traits, like someone's sensory sensitivity. How sensitive are you to bright lights? And if you are outside of the mainstream, if you're outside of whatever might be considered typical, then you might say that this trait is neurodivergent. But we also have neurodivergence or neurodivergent as an identity, that people say, I am neurodivergent. What does it mean in that context? That's where the definition starts to get really fuzzy. First of all, people use it differently. That'll make it fuzzy. But it's also just poorly defined, because if we're going to say a neurodivergent person has at least one neurodivergent trait, that's like saying there are people out there who are typical in every way. And so we have this other word, neurotypical, that sort of defines what if you were typical in every way. But there's almost like a poking fun with this, because who is typical in every single possible way. So a more helpful way that we might consider these identities is a neurodivergent person is someone whose neurological traits predispose them to some sort of minority stress. And a neurotypical person doesn't experience minority stress in their life from their neurology. I think that will encompass this without getting too in the weeds about where do we draw a line here, or trying to answer a question like, is everybody neurodivergent? I kind of laugh at that question because it's set up to poke fun. It's a fuzzy concept. And people don't love that in an academic circle, but we love this in this liberation and empowered way of talking about it, that we don't have to know every invisible line in the sand to be able to find community around our identities. Next topic would be the social model of disability. So this, again, is coming a lot out of the autism world, where the DSM calls it autism spectrum disorder. And the autistic community, there's many different factions within the autistic community. So I'm not trying to speak for all people, but there is a large body of people who are disability rights advocates who really dislike the idea of calling autism a disorder. Autism seems to be more like a phenotype, and that phenotype is not inherently bad or good, it just is. But then when it intersects with neuronormative society, now we see difficulties come up from that. And those difficulties are what disability is. Disability is, I don't have access to what everyone else has access to. The social model of disability says it's not something inherent in the person that causes the disability. It's the interaction of their individual traits with what is considered to be, well, you're supposed to not need accommodation for this stuff. So in that sense, disability stops becoming a dirty word. Disability just means I have support needs around this. And you know what? If we do a better job of setting up our world so that it's good for everybody, I won't even need additional support needs around this. And then maybe I don't have to even think of myself as disabled anymore, when in the context of my society, my life can be expressed in full without reservation. And then universal design is this concept I'm coming back to, like curb cutouts on streets. It's when we make the environment better for disabled people, everybody benefits, because we put curb cutouts on sidewalks so that people with wheelchairs can get up onto the sidewalk. But you know what? Who else it helps? Moms pushing strollers, delivery people driving bikes, people on scooters, folks who have mobility issues where it might be hard to step up onto a curb. It can help everybody. This is the kind of work that I want to be seen, that I want to see people doing in the mental health world, applying principles of universal design to treatment and getting our biases about neuronormativity out of the therapy room. So this is one version of a model of what autism looks like. And I'm trying to do this also with OCD. You'll see where I go with this. But where we see the DSM talk about autism in terms of social deficits and restricted repetitive behaviors, those are folks' complaints about autism. If we say what led to those restricted behaviors and social problems, we might look at a whole lot of subjective internal experiences that result in those. So the example I always love to give, and some of you guys maybe have heard me give it before, if a child comes into my office and I start asking them, the first session, I start asking them about their family and they won't make eye contact with me. And I ask them what they like, and they sit in the corner of the room and they grab their knees and they start rocking back and forth. And they seem very distressed by me asking about their interests, their family, what their life is like. I would think, this is a kid who's severely traumatized. This is no way a normal response to what I'm bringing out here. And I would probably call the Child Protective Services hotline if they're not talking to me or making eye contact and self-soothing and looking distressed when I'm talking about their parents. I'd be calling Child Protective Services. But if that same family comes in and the parent says, oh, he's autistic, he rocks, and he doesn't look at people, and he doesn't like to talk, then I might think, not me, but someone who doesn't know autism might think, this is just what he does. This is him in his element. This is happiness. But you get that same kid in his preferred space, with his preferred people, with his preferred sensory environment and his special interest that he can engage in, and you see a different kid. But wait, if I look at people testifying in front of Congress, what do they look like? They're looking to the side and rocking to stim and seeming distressed, because it's a highly distressing thing to be put on the stand and be interrogated in front of the whole country. And they do the same exact thing that the autistic person does. So is rocking, for example, an autistic behavior, or is rocking a soothing behavior? And putting this kid in my office was putting him into distress, but I didn't understand his distress. In that case, I really should try to understand what's going on below the surface, as opposed to just saying, people will like you more if you make eye contact. You need to talk or people will be worried about you, and stuff like that. So out of this understanding, we try to provide therapy that is affirming of natural diversity of perception and cognition. And what is neurodiversity affirming therapy? Google it, right? I'm going to tell you some ideas here, but I can't do a consultation for your whole practice and get this done in one slide. So start thinking about it. Think about consultations just as you get this information. I hope this leads to Google rabbit holes for people. So some of the points I like to make about neurodiversity affirming therapy is that conceptualization is so important, because we have to understand why people behave the way they do, rather than just focusing on getting them to stop their behavior. We can't just think about the intervention that stops the behavior without understanding why they're doing it. And something as simple as they were reinforced to keep doing it does not cut it for me. I need to know sort of the psychology of it. What's the lived experience of it? Otherwise, we might make missteps, and we use things like desensitization to things that are never going to desensitize. And I'll go into some of the difficulties with that in a little bit. Also, this accurate conceptualization allows us to use insight. And insight is such a valuable tool in therapy, but with a behavioral background, we tend to really eschew it, because once you have insight, it's not a guarantee that your disorder is going to resolve. And with OCD, particularly, just understanding, I know that feared consequence isn't going to happen in real life, never stopped anyone from doing their rituals. However, there's something missing in this, because I've also seen people really improve through psychoeducation, through understanding themselves, be able to dismiss a lot of their story and get a whole lot better out of it. So I think insight is really valuable. Someone said to me, I just needed to know it was possible to do it through insight. And ERP basically says, I don't care about your insights. So we want to make sure that in our psychoed piece, at the very least, we are bringing in the possibility that you could resolve some of these doubts just through understanding how you arrived at them. Another piece of neurodiversity affirming therapy. We don't just tolerate individual difference, we celebrate it. We say that I cannot possibly understand all of the diverse experiences of my clientele, and I need to listen to them, because if I'm saying that I'm the expert in everyone's experience, I'm going to be missing the boat on a lot of people. So we are proactive about saying, help me to understand you. And we're going to get ahead of this. We're not going to jump into treatment without first saying, where are your differences being punished by society? How can I help you get some self-compassion and a feeling of liberation around this stuff? Some more points. This kind of therapy is always free from coercion. So by coercion, what I'm meaning are practices that we're using on clients, basically without their consent, that are intended to benefit their support system. And there's a lot of types of therapy that may get into this. And there's a lot of practitioners that say, I can do behavioral therapy that may have had coercion in its origins without getting into it. And then we get into some gray areas. What do we do with folks with intellectual disability? What do we do for folks who put themselves into harm's way? What do we do for folks who are developmentally not able to get insight into their conceptualization? And then stuff like space, supportive parenting for anxious childhood emotions can feel coercive. I'm not going to accommodate you, so that you can get better. But even there's a degree of informed consent that we can provide to kids. So navigating this idea of coercion is really important, and minimizing it to the extent that we absolutely possibly can. Really, I do nothing coercive in my practice. I want people to know that no matter what happens, I just won't go there with people. I've heard stories about, you're either going to do your exposure homework, or I'm going to fill up a spray bottle full of dirty toenails and put water in it, and I'm going to go all around your safe space and I'm going to spray it into your room. Never in a million years would I accept anything like that. And I'd rather see the person starve to death in their room than spray them with dirty toenail water and show your attachment figures. The people that are out here to help you think that all of your thoughts, all of your feelings are irrelevant, and we are going to force this down your throat. That is so damaging for people's identity. Okay, but while it's free from coercion, it also has to be free from guardrailing. You're not going to find in the Merriam-Webster dictionary. That comes out of the neurodiversity movement. And it's the idea that we hold people back based off of their disability without understanding that there's a lot of difference in functional ability across a number of domains and contexts. So it might look like someone who was struggling in high school. We say, oh, you shouldn't go to college. That might be awful for you. And they might say, I'm going to go to college in my special interest. I think I'm going to be really successful with this. And we don't want to tell people this isn't for you. People are so heterogeneous that people should have access to the most powerful tools we have. And in my opinion, the behavioral tools we have are the most powerful tools we have. I want to make sure that people still can have access to that. Just we have to follow the rest of the principles. And then neurodiversity-affirming therapy values lived experience. That goes along with that celebrating of difference. And this word liberatory keeps coming up again. The work that I do with people gets them fired up. It's not simple. It's not simply like I just practice self-compassion. It's recognizing ways that they've been hurt and not jumping straight to forgiveness, but getting a thorn in your side about it, getting a little bit angry about it. I really think that good neurodiversity affirming work for folks who have been harmed by others' expectations of them involves a little bit of anger and defiance. And maybe that's a step along a path towards more equanimity, but maybe I'll get to that equanimity someday. I'm still pretty fired up. So if we see from the neurodiversity movement that we want to describe mental health conditions from the inside out, how might we apply that to OCD? So in OCD, we got our obsessions and compulsions. We might look at that and say, there's a degree of complaint in there. Why are you going on about this? Don't you know it's not real? And you're so inflexible about this behavior, it's causing problems for yourself and in your community. So has there been some work done about what the phenomenology of OCD really looks like? Yeah, there has. I'm not too satisfied with it. I think we have a long way to go. And I think this is where we have to learn from the autistic folks who have already done this work. So this is an example of one of the better papers that I found that has, Phenomenology of Comorbid Autism Spectrum and Obsessive Compulsive Disorders Among Children. That should have the phenomenology in it, right? But what does it look like? Their descriptions, they talked about comorbid conditions along with it, things like social anxiety. And they talked about the themes, the content areas that folks with OCD have, and looked at things like with OCD and autism, are you more or less likely to have this theme than with OCD alone? I want to see it look more something like, let's get to what I want to see it look like. So this is a very traditional model of what OCD looks like. We get an obsession that causes anxiety. We do some sort of safety behavior that relieves the distress, and then that takes away that bad feeling. And through that take away a bad feeling, we get this negative reinforcement loop. We're more likely to do the compulsion over and over again. Cool. There's the inference-based model too. This is still one of the main ways that I think about OCD though. So what does the neurodiversity movement add to this? We already can see where compulsions are coming out of. They were some protective behavior around anxiety, and then the relief, this loop, caused them to become compulsive. But where did the obsession come from? I also think I could have put some question marks pointing straight up into compulsion too. We'll get there too. I got some thoughts about where some of these obsessions come from. I think there are a lot of subjective experiences that folks have regardless of having OCD, having that behavior loop of compulsions, neutralizing the distress that comes out of obsessions. I think these are just natural variation within people. So here are some of my thoughts about basic neurological variation that predisposes people to OCD. And where am I getting this out of? Not out of a research paper. This is out of asking my clients and workshopping this material with therapists with lived experience over the past year. If you have thoughts on this, by all means, let's talk about them in the Q&A. Send me an email. This is by no means done. This is different than I even presented it at the conference by a little bit. This is just a work in progress. I want to figure out how to ask this as a research question. I'm dumping here, but I'm going to go one step further. If any of you all know who Ari Neiman is, I think that's how you pronounce their last name, who is the head of the Autistic Self-Advocacy Network. He talks a lot about the disorder part of autism and the traits part of autism. That's what I'm getting at here, that there are traits that predispose us, and that the disorder would be when we're stuck in a loop with compulsions that is ruining our life, when we are believing in the obsessions and we're in this state of inferential confusion that's making us feel this horrible, not being able to trust self, not being able to know what's going on in our environment, and just like the most awful thing might be happening, or we might be the most awful people in the world. So let me go into some of these traits that I think are pretty natural variations, but if you get an accumulation of this, that could be a springboard for OCD. So first is, I think that there's a natural variation about how sensory people's cognition is. There are some people who have really well-developed imaginations where there's a lot of sensory components to it, like touch and smell and really highly developed visuals. So if I'm standing near the top of a staircase and there's someone standing in front of me, I might have a brief thought. I do not have OCD. I might have a brief thought like, oh, I could push this person down the stairs, but really there's no emotion with it. There's nothing beyond just the briefest thought about, oh, I could push them. But what my clients describe to me is a really sensory image with sound and emotion in their body and a feeling of physical tension in their body, like they want to push, and a visual of the person's face as they're so distressed falling down the stairs, and like red blood and the sound of clunking going down the stairs, like an awful sensory experience that would really bother anybody. And what happens with this is I walk right on by the guy, and the person who's got this really highly sensory thought process walks by the guy, and we have different interpretations of what just happened there. I say, oh, that was just a thought. And they say, oh no, what was this? No one else seems to be distressed walking by people at the tops of stairs. What's going on with me? Why do I do this? Maybe I'm capable of pushing them. And then they go do their ERP, they go do their ICBT, whatever. They resolve the obsessional narrative. They don't have to do their compulsions. They're not avoiding the top of the stairs. Their hands aren't in their pockets. They could even walk up and pat the person standing in front of the top of the stairs right on the back and know with full conviction that person is safe. But if their thoughts are highly sensory, it still might give them the image of pushing this person down the stairs with all of these sensory components, even though they know they're not going to do it. And so they walk on right by the person, same as a person without OCD would do. But it's like they stepped on a tack and they just kept walking, whereas I didn't have to do that. And when we deal with the OCD, some of the neurodivergence might remain. And neurodivergence isn't the only way we're getting at OCD. I don't want to get lost in this and say what's really happening is this neurodivergence thing, and then OCD emerges out of it, because I think there's many pathways. It's not all this different neurology that we're born with. I think the example that people resonate with the most is this highly sensory thoughts. That's the one I lead with. Okay, the next trait I think is distributed across the population is something more like what happens in folks with tic disorders, where they get a premonitory urge and then they either do some sort of competing response until that urge passes, or they do something to satisfy that urge. And we know about all these physical actions that feel like premonitory, or that feel like tics, or that are tics in how they function. But I have folks with OCD tell me all the time, I was blurting this out in my head, or I it was so annoying how my thoughts kept returning to this over and over again. It feels more like a tic than someone who's voluntarily putting their attention on something. So I think some of the neutral obsessions that we see, musical obsessions, maybe even some of the hyper-awareness obsessions, these seem to have a really tic-like quality to what's happening with thoughts. And the next thing that people describe to me, copropraxic urges. So in the Tourette's or in the tic world, we have the idea, the stereotype of what Tourette's is not what people usually look like. The stereotype sounds like someone who is cursing uncontrollably. And those curse words are a rare sort of tic called coprolalia. So copra is like feces, and then lalia would be speech. So this is copropraxia, feces and action. So this is an urge to do a action that is, we could call it ego dystonic, or we could call it repugnant, or we could call it potentially harmful or self-harmful. So these urges to act in ego dystonic ways, there's a lot of folks with OCD who really do not have this urge at all. There's this thing called thought fusion, if you've followed up on if you've learned the ICBT language, about predicting I'm going to have this. And then, oh no, it's like I did have it. It feels just the same to me. But that's not just what my folks with OCD tell me. My folks with OCD tell me sometimes I really am having a real urge to blurt out a curse word or a slur, or to grab something that would be painful to me, and I don't act on it. I think if you were someone who was going to shout out a racial slur in a work meeting, you might have figured out some competing responses to keep yourself from doing that. And these urges, maybe these lower level copropraxic urges, can become part of your narrative. So helping people to say, what is an urge? What is more obsessive, just a thought fusion? Maybe we can help people understand and validate for people why this didn't go away when they've done their ERP around it. Another point would be dissociation. So this is not in the diagnostic criteria for OCD. There's a whole section on dissociative disorders. We see dissociation in trauma, but clearly we'd see some dissociation in OCD as well when people are going into this scary story and as their eyes go off to the side, they are losing touch with what's happening in the here and now and going into an imagined world in a dissociative way. So people who are prone to that might be more likely to develop these obsessive narratives, might be more likely to get stuck in an imaginal absorption. Okay, the next trait, I call this hyperempathy. Folks in the neurodiversity community about autism talk about hyperempathy. In autism, it's assumed that folks lack empathy, which is so ridiculous. I just can't understand how that ever became part of the narrative when you see autistic people just losing their minds about injustice everywhere in the world. Like, where is this lack of empathy coming from? I think we just see differences in empathy. We see, I don't care about that. I don't have a ton of empathy for that. I do care about this. And my empathy is off the charts because I experience the world in intense ways. So I borrow this idea of hyperempathy and say, it's not, you would not say, oh, he's got hyperempathy, so that's an autism diagnosis right there. Just as you wouldn't say he's got hyperempathy, that's an anything diagnosis. But I see this as part of, the breeding ground for OCD, where all these hyper responsibility beliefs that go into our obsessions really get tied in with hyperempathy because of how strongly we feel about things. Then we feel personally responsible to take care of them because I could not tolerate this going any other way. So we see folks with OCD, not just with autism, but we see some of these similar behavior patterns like justice sensitivity, honesty sensitivity, and having distressing emotional pain watching others suffering. So I think that is a possible precondition too. And going up to the right here, another trait, maybe this goes along with the sensory sensitivity below, but I pulled this out different, that we've got disgust hypersensitivity. That would be subjective differences in the propensity to experience disgust, like the likelihood and what stimuli give you the disgust feeling, as well as the intensity of the experience of disgust. It's pretty common sense how we could make a really obsessional narrative about, I can't trust my common sense about this, when we are experiencing intense disgust feelings and everyone else seems to be totally fine with the same stimulus. I have to have an explanation for why I can't do this and come up with a story about it. Another one would be not just right experiences. So this does come straight out of our understanding of OCD, but there's also literature that says is not just right experience more tied with the tic-like presentation of OCD. We do see in the DSM that OCD with and without tics are differentiated from each other. And maybe this like needing to satisfy an urge is a little bit what's happening and not just right experiences. But I also believe that people can have this experience of like being really satisfied with completeness or feeling discomfort with incompleteness or with asymmetry, and maybe even do some like I do this until it feels right as opposed to I do this until it looks right or I got some external criterion met. And I don't think that is really that pathological for folks to have this trait, but not everyone has it. And when you do have it, and especially in more extreme sensitivity to it or intensity of feeling it, you're more likely to develop a narrative. I can't do this because this not just right experience means something. Okay, another one we keep seeing at the conference, these talks about sensory sensitivity. And there's clearly some overlap between sensory sensitivity and OCD, but it's not in the diagnostic criteria. I'm just trying to bring it into the discussion about how natural variation about liking or disliking certain sensory things can lead to an obsession. An example I like to use is if somebody doesn't like the inconsistency of fruit, sometimes it's sweet, sometimes it's sour, sometimes it's mushy, sometimes it's firm, and they really avoid fruit all the time. Maybe they have avoided fruit and people bug them to eat it. And so they have a hard time explaining why they hate fruit. And they start coming up with a narrative about something like it was sprayed with pesticides. And because of all the little nooks and crannies, you can't possibly wash it all out. And I get this icky feeling in my mouth. It's the pesticides. Well, maybe it was actually like a texture thing. And we created a bridge between the felt experience of it and why I have to do the compulsion of avoiding it. Next one would be someone who finds repetition soothing. A lot of folks are more drawn towards novelty. Some folks are more drawn towards predictability. We all have different contexts and different times of our life where we're going to be drawn more towards one or the other. But folks who find repetition soothing are more likely to do something in the same way over and over again. And then when someone says, hey, let's try this in a different way, they might have already developed a rationale to say, no, I like it this way. But if it doesn't sound like I like it this way, it might sound like I need to do it this way. There's only one way that I can possibly do it because at this point, I've developed a story about every other way causing some sort of harm. And finally, just the personality trait of neuroticism. People who have more labile emotionality, people who are more anxiety sensitive are going to be more likely to develop OCD as well. Just they're going to be more likely to develop depression or anxiety disorders or eating disorders or a whole number of other traits. If you're going to take one thing away, if I said I'm going to talk in this hour about what my big pitch is, I want to see OCD described in a model like this from the inside out. And I want to see people who know something, do something about it, to speak up on one of these traits, to add to this model or come up with their own model. That's what's happening in the autism world. And our discourse is so much richer for it. No one is going to own the truth about this. What we're going to try to do is develop the research questions so we can do what Ari Neiman did in devising some good methodologies to ask these kinds of questions within our community. I'm a clinician, not a researcher. I'm trying to build out the theory based off of what I observed. I'm doctoral level, but I'm not turning around to go become a researcher. That's not my jam. So I hope that this kind of stuff gets in some of your guys' ears and it starts to creep into the way that you talk about OCD. That's my hope. So I'm making this big point. I'm not sure if I'm going to keep this language forever. This language makes the most sense to me right now. OCD, a disorder, exists when a behavior becomes a compulsion by getting stuck in this functional loop with an obsession through the principle of negative reinforcement. It's a disorder when it's ruining my life. It is not simply being wired to have certain intense subjective internal experiences. That's a phenotype. That is, I have this trait level presentation. And I'm not saying phenotype like the OCD phenotype or the autistic phenotype, although there is a concept of the broad autism phenotype. I'm saying phenotype in terms of this is my expression of sensory sensitivity. This is my expression of empathy. This is my expression of what my thoughts feel like from a subjective experience. So I see that as not being a disorder, that just being an expression. OCD is also not simply a predisposition to rigid and maladaptive behavioral patterns. That is also a phenotype, like we see in compulsion. We can get folks who have rigidity about their preferences, rigidity about what they're willing to do. Starting out from a really rigid behavioral pattern is not enough to call this OCD either. We really need that interplay. And I know the DSM says you can have either obsessions or compulsions. So that's what I'm going to say here at the bottom. People can have predispositions towards these cognitive and behavioral patterns and not have OCD in my claim here. It's the interplay between the two. Yeah. So sometimes pure O could have hidden compulsions. We see the either or in the DSM. Sometimes it could have a hidden compulsion, or maybe there's other factors maintaining it, like my question marks of what went into obsession. I think that there's many possible paths through combinations of risk factors that arrive at this OCD negative reinforcement loop. I don't think that it's just neurodivergence. I think that, and I don't think that it's one neurodivergent profile. I think that nothing is necessary and nothing is sufficient. Maybe there's some morphology in your basal ganglia that actually is necessary, but outside of something that is about brain structure, about our the whatever that is, the cortical thalamus limbic loop or striatum thalamus limbic loop, I think that there are many predisposing factors where no one is absolutely necessary. So some forms of neurodivergence predispose people to OCD, and there's probably some psychology to that etiological link. And there's also probably something neurobiological, like this idea of secondary or organic OCD, something like PANS, or saying that if this is what your brain looks like related to autistic neurological traits, then OCD is likely to emerge from this. That would feel pretty neurobiological. But I'm a big fan of bringing our curiosity into the psychology of how these things intersect. So that's where I'm going to go in the second half of this talk, about how to be curious about that, how these things can intersect on that psychological way. So not just neurodivergence are risk factors that lead to this. Also, there's a lot of beliefs about self and ethics. If you think that the path to heaven is as narrow as the eye of a needle, then you can develop scrupulosity OCD just out of that belief alone. And this relationship between these reflexive internal experiences and identity. What do I do? How do I feel about my response to aversive stimuli? Do I tell myself I'm brave, I'm empowered, I'm a badass? Or do I feel like I'm a victim, I'm incompetent or incapable, and poor me? And believe me, when someone gets into a poor me headspace, I have empathy for that. And it is not, you're going to need to knock that off, or you're never going to get rid of your OCD or something like that. But I do want to understand how someone's cognition might lead into these patterns. Trauma is another thing. This is what we keep saying in our community. Trauma doesn't cause OCD, but that's like one-to-one correspondence. Trauma doesn't cause OCD. If you've seen OCD patients for a decade, how many people are going to tell you, oh yeah, there was a traumatic experience, and after that, I had OCD? Like, it happens all the time because it goes into our reasoning process. And trauma can also do things like cause us to have intrusive experiences. It leads to dissociation. It leads to these other neurological predisposing factors. So we have a multifactorial interaction effect that happens between these. And then we also see like psychosis. That seems weird because we don't think so much about psychosis in our community, but what is the schizo-obsessive idea all about? And also, what is OCD with limited or absent insight really look like? how can you differentiate psychosis or delusion, particularly, from OCD with absent insight? Now, I had a really tough client on this, and I asked myself this question many times, and I did a lot of great consultation with some great folks on it. And at the end of the day, I got a lot of, I don't know, it could be really tough to parse apart what the function is when it's really deep into people's internal experience. But I just like, acknowledging that it's not as cut and dry as we might have made it out to be. And then this last point is just so crucial because we see this with so many folks with OCD, that this like social learning experiences with other people teaches this process of self-invalidation. And self-invalidation causes distrust of senses and self. And we see it all the time. Oh, I didn't see this the way you did. You're wrong about it. You're in a family or in a community that tells you over and over again, no, it's just not the way that you think of it. You're wrong. And then you just learn to distrust yourself. So we can break the OCD behavioral loop. We can treat OCD so that you don't have to do compulsions anymore. And so that really you are not so anxious anymore and your life gets so much better. And if we leave this part out of this discussion about neurodiversity, then I am guilty of all the things that people might want to throw at me about, oh, you're over-identifying with diagnosis or over-identifying with this idea of neurodivergence, and it's an excuse. No, it's not an excuse, just describing what happened. And beyond that, I'm saying that there are treatable parts about this. There are parts that are not just treatable. I don't want to say curable because we have the whole thing about it can come back at any time, with a new theme or a new trigger or some stressor in life. But we can learn the skills to break the negative reinforcement loop, and we don't have to go back to compulsion, but there's probably some things that will remain even if we treat that negative reinforcement loop. So I put neurodivergence because, like I'm saying with the top of the staircase, the intrusive image may remain in some way. But also, the whole idea about trauma didn't cause OCD, but we have to treat both trauma and OCD when they're both present. I might treat the OCD and the trauma still remains. If I treat the trauma, the OCD might still remain, or sometimes I've seen actually treating trauma can reduce baseline stress, and with less, daily stress in people's lives, they don't do the OCD pattern anyway. We didn't really treat the OCD. They did their own self-help version of reintegrating into their avoided activities through the help of the trauma work. But really, again, we were treating trauma. We weren't going into the obsessive process or using all the psychoed that comes out of OCD. Okay, so that is the first half. The second half, we're going to talk about other forms of neurodivergence that are not OCD and how they interplay with OCD, and then how we can do treatment for OCD with co-occurring conditions, as well as OCD as a standalone, with knowledge of how these individual traits are creating OCD or are creating the grounds for a negative reinforcement loop to be learned. So these are just some ideas. This is another area where I hope I've read a lot of good writing on it. I've had a lot of conversations with some very bright people, had a lot of conversations with people with lived experience who know this so deeply well. Sarah Staunton, who works for NoCD, wrote a great blog for NoCD that describes their process of going through ERP and understanding, how this was going to work. So I'm not trying to say, hey, after this, you're going to fully understand this. I'm saying this is a team effort. I'm not the only one saying this. We got to build out the language that other people are going to put in the discourse, because guess what? The textbooks are not getting into the psychology of this. They're not getting into what we've learned from our patients. They're talking about neurobiology. They're talking about comorbidity. This is advanced stuff for people who can conceptualize, for people who understand what these phenotypes are like and can put puzzle pieces together in complicated chains of you did this and so you did that, and you felt this and so you thought that. That's our work to do. I hope you guys work on this. I need more discourse on it. I guess that's where we're going. But then I go and I read the literature on this and I say, oh, it's sorely lacking in some of these like fundamental ideas. So here are some of the ideas I want you guys to be thinking about how these three conditions can lead to OCD from a psychological perspective. So in autism, two of the really popular ones are the intense world theory and the idea of monotropism. I don't think that either fully explains this broad autism phenotype, even though I'm not a huge fan of that concept, but as an organizing principle, if that's what we're trying to explain, I think that there's room for both and more in there. So the intense world theory is that autistic folks, their neurons may be bundled with more neurons, like a higher count of neurons, or perhaps different myelination. And there might be like hyper intense bundling and hypo intense bundling within the same brain. So we'll see a lot of typical sorts of bundles and some hyper connected bundles and some hypo connected bundles. And then we see it in the person's lived experience that some experiences are really intense for them and some aren't really firing. We're not getting the same kind of response. So what does that lead to? Hyper intense sensory things. We talked about how that can lead to an obsessional belief, or it could lead to compulsive avoidance that turns into an obsessional belief. Hypo intense can lead to, why do I even think this or feel this? I'm not sure what this feeling is. It doesn't make sense to me. I'm not sure if I understand even how to name what this feeling is. And then you could see how that could lead into things. I have another slide on this one, so I'll move on from this one and hit the ADHD ones, and we'll come back to that, the autism ones in specific, because it's just so commonly comorbid. ADHD is another one that sort of has this breeding ground for obsessive beliefs. We see executive dysfunction. People actually have problems when their environment can't accommodate their executive dysfunction, so they distrust themselves, and then they believe that they need to check a million times or whatever their ritual number is to make sure that they didn't make one of these executive function mistakes. But in truth, that executive function mistake it's an out of context fact. It is true, but it's irrelevant to the claims that their OCD is making. Also in ADHD, even though this isn't in the diagnostic criteria, we see emotional lability and hyper-emotionality. We could see how that is sort of like a form of neuroticism that could lead to intense experiences that we would explain away with an obsessional story. We also see in ADHD, I'm really grateful to the neurodiversity community for doing this kind of research, stuff about the social difficulties that folks with ADHD have, particularly criticism. How much we criticize kids who are hyperactive, and that criticism is so damaging. And what happens is we'll see, like, folks with ADHD often have rejection sensitive dysphoria. Minor sorts of criticism get felt as being total rejection and like you're a horrible person, and you get experience after experience of these intense forms of criticism, and now everything starts to feel like criticism. There's a really great paper about ADHD experiences of criticism. I'm gonna encourage everyone to go Google, or if you email me, I'll send it out to you if you have trouble finding it. But yeah, that's the kind of thing that leads people to distrust self. And then tic disorders, the tic-like quality of thoughts and premonitory urge, these are confusing subjective experiences that could both lead to OCD as well. There's probably something neurobiological happening there, and probably also something psychological happening there, as we were saying, with all forms of neurodivergence here. And that psychological piece might come out of things like people judging you, people are self-isolating also, so that I'm not getting regular feedback because I'm embarrassed about a tic, or I'm afraid of harm that might come out of a tic. Yeah, and then also that tic-like quality of thoughts, we're saying, I think sometimes OCD is getting diagnosed where really it's sort of like more of just a neurodivergent way of experiencing thoughts. So all of these things have something in common. These experiences predispose people to doubt what they already know, to think that their knowing is wrong and that they need to trust somebody else, because otherwise they're going to be in trouble. So differential functional assessment, I'm talking specifically between autism and OCD, is going to be really crucial for anyone who wants to be a neurodiversity-affirming OCD therapist, because autism is probably underdiagnosed, but I think there's a diversity of opinions on this. And I think that what's falling under the broad autism phenotype increasingly in the autistic community is being understood as autism with low support needs and no less valid than anyone else's autism. And then we see these same sort of neurological traits present in it. So I think that if you treat OCD and you know a little bit about autism, you got to look past just the most stereotypical presentations of autism into some of these other differences. So I love Matt Lowry's model, but there's a bunch of models out there. Go read up on it. Go do a training on it. This is not a training in how to see autism through a neurodiversity lens. It is just a real quick snapshot, and there's tons of great information. I like Joel Schwartz's training on it, but that's just one name I'm pulling out of a hat. So many people have done excellent work on this. So some differences that we see are that in the behaviors that are more attributable to OCD are often really distressing for the person with OCD. They feel like that this behavior does not represent them. They wish they didn't have to do it. They hate spending their time and energy on it. They hate thinking about it, and it's uncomfortable. Whereas the person who's autistic, who's doing what we call an RRB, restrictive repetitive behavior, or maybe we might call this engaging in their special interest, or doing a stimming behavior from a different perspective, they are enjoying, they are getting regulating benefit. The action themselves are not saying, oh, I wish I didn't have to do this. They're saying, I can't wait till I get to engage in this thing that is really identity affirming. And what we'll see is that if you try to take away someone's identity affirming regulation sources, we don't get desensitization to the stimuli that we're hoping that the person is going to desensitize to. They were wired to have an intense reaction, and in some cases, they may desensitize some. In many cases, they don't really desensitize. And then we need to say, okay, why were you trying to engage in this? Actually, more than trying to get rid of some uncomfortable experience I was having, I was saying, the most affirming parts of my life are when I get to experience peace, not just peace, joy, happiness. Autistic people deserve to feel at peace. They also deserve to feel joy too. So engaging with these sorts of things that might look pathological to someone who is only doing them because of a scary story in their head that had no grounding in reality is not pathological for someone who just wants to experience the same kind of peace and joy that everyone else gets to experience. So looking at these differences, there is a great deal of education that our community needs to put out about how to do this functional assessment that gets beyond what the textbook chapter says. There are some folks out there who do good consultation on this already. There's some good blogs on it, but we need more. We need this to be part of basic training in doing OCD work. So some of these differences, like a sensory intolerance, is not an obsession, it's a sensory thing. Stims, that is putting in positive sensory input in a regulating way, it's not a compulsion. There's no scary story that it neutralizes. Special interests are not the same thing as like obsessing. Sometimes in a colloquial sense, we'll see someone say, all that person talks about is what they're interested in. They only want to talk about Star Wars or something like that, and can't let anyone else get a word in edgewise. Why are they so obsessed with this? What, do you have OCD about it? That's not OCD at all. That's having a special interest or a hyperfixation. And then there's this idea of the concept of monotropism that comes from the autistic world. And monotropism is basically being really immersed in one line of attention and having a really hard time pulling away from that. And that might be something that underlies some of these other traits. That might be the neurological background. I don't have enough evidence to point to that. And it doesn't, people will endorse monotropism as part of their lived experience, but I find that like building the model, people like the more plain language approach to it. So I don't use that in that way. But could monotropism also be one of these just neurological traits that differs across the population? And It's present in OCD to a lower degree. There's the monotropism questionnaire. Yeah, same with hoarding behaviors. You might see someone who's got a collection and it's the most valuable thing to them. And you say, oh, you got a problem with acquiring, you got a problem with getting rid of. Actually, I've made my space to my identity. So how about we look for things like, can I use my space in adaptive ways? That's the better question to ask then. Is this hoarding? Is this OCD for someone who is getting a lot of joy in it? The hoarders that more are an OCD case, there's going to be a lot more like distress around their hoarding. But we can see both too. Yeah. I could go on and on about all these different things. Executive function challenges are not compulsive slowness, like that one gets mistaken. Relationship differences are not compulsive needs for reassurance or ROCD, or some people get a lot of their identity and they get a lot of positive STEM activity through their relationships. And it's tempting to pathologize this, but in the autistic community, you find people who connect in this way and they want to be together all the time and they want to process every thought. And that's not necessarily pathological. Communication preferences are not compulsive. I need you to say this in this particular way or my plane is going to crash. That would be a scary story that's compulsive. But this particular sound is very regulating to me and very pleasant to me is not necessarily compulsive. So say it in the way I like to hear it. Or Gestalt communication patterns are not compulsive. And then I've made my claim here about mental tics are not obsessions. Hyper-responsibility versus hyper-empathy. Are hyper-responsibility cognitions in OCD the same as hyper-empathy in OCD? I don't know. I try to do functional assessment around this. What does it feel like for you? Why are you doing what you do? And we're going to adjust our intervention accordingly. And then interoceptive difficulty. So if you look on the chart over here on the right, I really like this breakdown. The idea of interoception being different in autistic folks might look like not knowing if I'm hungry or thirsty or need to use the bathroom. It might look like a huge tolerance for pain. It might look like not understanding my emotions. Alexithymia, feeling all emotions feel like the same thing. I feel them in my chest or I feel them in my face. Whereas someone else might say, anxiety feels like butterflies in my tummy and I get a headache that happens in the back of my head. And depression feels like a heaviness in my body. And joy feels like this. My people, these are all confusing emotions. I couldn't tell you the difference between surprise and fear. I just don't know it. Yeah. So when we have that confusion about affective state, we should be asking the question about, do you know or do you not know? Because for someone with OCD, they can look at a doorknob and does it look locked? I heard the lock slide home and all that. It looks like it's in the locked position, but I still distrust my senses about it. To check that doorknob to see if it's locked, what we would like to do is just look at it. It looks locked, it's done. Or maybe jiggle the handle one time. It's done. I know that it's locked. When we check our internal affective state, do I want to hurt this person? Do I love my partner? Am I capable of harming a child? We should be able to look as easily as we check doorknobs. Do I want to harm a child? No, done. Folks with interoceptive difficulty are going to have problems with that. So I want to ask the question, is this the kind of thing where I can check inside and know or not know? And yeah, folks with OCD are going to have a hard time answering that question. That's why you need to be able to understand the phenomenology. What is your client bringing to you and help them find the language that they're expressing and understanding themselves. Folks want to jump into treatment. And I want to stick with conceptualization because that's where like the magic happens, where we're deciding how we're going to do this kind of treatment planning. I love conceptualization. So that was a big complicated slide. If you're going to take away anything from this and you don't already know this idea, STEMs are not OCD. Special interests are not OCD, and sensory intolerance, it's not OCD. You guys can come back to this slide. Got one more point that I am super into right now that's tangential to this presentation, but I've got some folks here who are like-minded and I wanted to just bring it up. I see a particular route to something we might call it OCD shame. Shame is an emotion everyone experiences. It's real common in OCD. I see a route towards a sort of like deep shame that folks with OCD often bring into the office, where they're in some sort of neurominority. These traits are different, or maybe it's an autistic presentation or ADHD presentation. And that leads to social rejection. Not just social rejection, but rejection of thoughts and opinions, rejection of what I know to be true. And then this rejection for being different leads the person to basically reject their own thoughts and feelings. Everyone else is saying this is wrong, so I guess I'm wrong. And they blame themselves for the problems in their lives because they must be wrong about their approach. Now you add in a piece of hyperempathy, and now you got people blaming themselves for being rejected and feeling this confused hyperempathy towards the person who rejected them about, oh my gosh, I've hurt this person so much. It's because I'm so awful. And I see their frustration with me, and it just leads me down this pathway of shame. So that confused hyperempathy leads to self-blame, hate of essential self, and this process can fuel OCD. I love bringing this one up with clients. So I'm going to talk next about what neurodiversity affirming care might look like. And we're going to talk about some of the ways that behaviorism doesn't respect these differences and this functional assessment question when we're doing it in a sloppy, haphazard sort of way. So this is a really popular, I don't know who deserves credit for coming up with the idea, but the problem with pounding a square peg into a round hole is not that the hammering is hard work, it's that you are destroying the peg. Treating autistic folks with OCD with ERP and saying, oh, I hate doing this work because it's so laborious, might be an indication that you are fighting with your patient and you are trying to take their edges off. So let me hear some more about that. Autistic folks in particular, folks in the neurodiversity movement in general, have some hesitation to even engage with people who practice behavioral psychology. We just have to accept this as a fact. It's already out there. There's no bringing it back. And guess what? It's justified. Not every behaviorist is a bad guy, but I hate even saying that. I just know that there's going to be behaviorists who are watching this who expect me early on to be defending behaviorism. Yeah, I teach a seminar. I don't teach anything but behaviorism in my seminar. I am a behaviorist. That's how I see the world. The model I want to teach this from is the behavioral model. I'm not using it an inference model. I am a behaviorist, but I can still admit that this neurodiversity community has experienced a community trauma at the hands of behaviorists, such that there are folks who have not even gone through coercive behavioral therapy who are still traumatized by the knowledge of it. I really enjoyed a really excellent presentation at the conference, and Eric Storch was presenting some great data about the acceptability of a variety of to treating OCD. And we see that very few people actually drop out of ERP. People generally find it highly tolerable. Great, there's great data to support this. Most of my patients probably would agree with this. Also, I told you guys at the beginning that I run the practice in town that gets all the overflow from the people who dropped out of a really great IOP in my town, and they say these things. Maybe those numbers could use some revisiting. Maybe we need to figure out how we're asking that question. If I'm going to point to any data point, we also say that deep brain stimulation is really well tolerated amongst OCD folks. I really appreciate that. That's good. I'm glad that we have a treatment that we can go to that's still tolerable. It's better than a lobotomy, but I don't want to get surgery. I don't want to have to get a battery pack in my chest replaced every year. I don't want to have to deal with what happens when the battery starts to run low and my symptoms come back and there's really nothing I can do until it's time to go change that battery or get another surgery. I don't want to take the risks. I don't want to go under sedation. I don't want to have to tell people I got a surgical implant in my brain. So even though the study says that it's well tolerated, I'm curious about how people might describe that from subjective perspective, because I've been doing ICBT with a lot of folks, and that's really well tolerated. And I'd like to think that most people would prefer to talk with me about ways that they have invalidated themselves, and being able to feel confident in that the self that they believe themselves to be is their true self. Like, that's really empowering work. That's not just tolerable. It's like enjoyable. It's a very affirming. It's liberatory. So when we say that ERP is really tolerable, and we cast some doubt that all these folks who are in this movement who are decrying ERP were really traumatized by it, just ask that you think about why you are dismissing all of these voices and why you're turning this into either it was nothing or all, because that's a lot of where the discussion goes. And I see it from all sorts of different pieces of the community. But yeah, I'm going to stand on firm ground to say I am a behaviorist who sees the community trauma that has been inflicted by people who practice the kind of practices that I practice. Okay. So what makes behaviorism potentially traumatic? This is not in every piece of behaviorism, but that's where it's like behaviorism gone wrong. The first is that the premise of the behavioral process was fundamental change. We have the intention to change who you are, change your identity, change your traits. So we would say that we would want neurodiversity affirming therapy to be like, you are not going to change who you are. You're going to learn skills so that you can be flexible if you want. And also find spaces where you don't even have to use those skills, unless it's something that just is harmful to you or harmful to in a way that you find to be values incongruent, but you have total agency about how you want to use this stuff, because we assume that you're not going to fundamentally change. It's always going to be somewhat of a negotiation with your environment. The next principle would be coercion, where we do not wait for the patient to give consent. We say, we're the expert and we know what you need, and we're going to do it to you, and it's going to make you better. And we've given some examples of how that could happen in really disastrous ways, potentially. If you think the way I do, it seems like a disaster, or maybe ways that are more mild, the way that like Eli Leibovitz practices space, or I've seen some really sensitive folks practice space where kiddo is getting on board with the approach, although when it's time to go to bed at night, it still might be a difficult moment, but not necessarily the same thing. So if you're not asking yourself, who's the expert in the room and how was consent given for this, then you're running the risk of missing out on possible coercion. And then this last piece about learned helplessness. This is also just so crucial. In our treatment community, we mostly all started learning on habituation models. There's maybe some folks here who are younger or newer to the profession that learned about inhibitory learning in their first few go-arounds of learning how to treat OCD, but most of us learned the habituation model. So the habituation model, the idea is you sit with a stimulus that's distressing for long enough, and then you don't have to respond to it anymore. It's like we tested it out on sea slugs who put out their little eye stalks, and you zap them and they retract their eye stalks back in their body. And then you wait until they stick them back out and you zap them and they put the eye stalks back in, and you keep doing it over and over until they're like, oh, just keep the eye stalks out. I'm fine. I don't have to do anything different about it. They're not really learning anything. They're a sea slug. They don't really have so much cognition, not the way that we think of like human beings learning through operant conditioning, but they do habituate to this stimulus. And we use the word desensitize sometimes to be the same thing as habituate, but those words are not really the same. But a lot of times when we're contrasting habituation with the inhibitory learning model, we're acting like what we mean is desensitization, but it's not necessarily the same thing. And then the inhibitory learning model is saying that through expectancy violation, what I believed was going to happen didn't happen. I learned, I guess I don't need to do what I thought I needed to do to be okay in this situation. And rather than an old behavioral response or behavioral repertoire being forgotten or removed, extinguished, instead, we're looking at a new mental model for what happens when I do this in this context. The more I rehearse it, the more I practice it, that's what my thoughts are going to bring up as my first expectation. So now through repeated expectancy violation and consolidation of learning, eventually what I expect is this is going to be tolerable. This is going to be fine. So that enables people to face stimuli that they previously found intolerable with a new degree of willingness. Sometimes they're desensitizing them. A lot of times they're finding it wasn't as bad as I thought it was going to be. I told myself a scary story and it didn't prove to be true in real life. And I didn't really need to desensitize. I just needed to get rid of the story. And this is going to provide learning experiences that were missed out through avoidance and help us get rid of obsession that way. Hearing this model for the first time, I'm like, hallelujah, inhibitory learning. It takes away everything that I was worried about when my clients were like, yeah, I'm not desensitizing, I'm not habituating, my SUDS level is staying up. I can say your willingness also came up, and now you're able to go to the dentist, and you really needed to go to the dentist according to your own values. And so great, we got the inhibitory learning response or outcome that we're looking for out of this treatment, not just habituation. Cool, loved it, loved it, loved it. Over time, though, some doubt started to creep in about, is everything that we're calling inhibitory learning truly inhibitory learning? Because let's think about Seligman's experiments with learned helplessness in dogs. He puts these dogs into a contraption and he zaps them, and they try to escape the contraption because it hurts, and there's no escape. So he zaps them, and they try to escape, and he zaps them, and they try to escape, and he zaps them, and he zaps them, and he zaps them until they just lay down and they look lethargic and depressed, and they stop trying to escape. And then he makes the contraption now escapable for dogs. And if they've learned to just accept the shock, then they don't escape. They just sit there and take it. They learned to be helpless. Okay, so to apply this to our clients and to ourselves, if there's some sort of aversive stimulus that we have to face all the time, and we learn that we can face it, it either's got to desensitize, or we got to learn that our obsession wasn't real, and then it's not so aversive anymore, or it's got to be my values as the reason that I'm going for it, and I'm being flexible around when am I doing this aversive thing or enduring this aversive thing for my values. And where it becomes really insidious is this distrust of self, where we outsource identity to some other authority. This is what you're supposed to like. This is what you're supposed to not like. No, you really feel joy in this situation. Put it on your face. I want to see you smile in this situation. Make your disability as invisible as you possibly can. And then we're going to call this recovery. And because these folks are self-invalidating, they're calling it recovery themselves. I can't abide this. I'm not okay with this. Behavior therapy that gets folks who have anxiety or an intolerance to face what they are so averse to absolutely needs to be empowering and full of agency and full of values and preferences and self-understanding and identity, or we're running the risk of this learned helplessness stuff. And I know the clients that come out of behavior therapy with this learned helplessness perspective. I know them intimately, and yeah, I'm curious what people will have to say about this perspective. I don't think I'm the only person saying it, but I can't go back on that. This is real. This is reality. I want to hear Michelle Krask talk about that though. These are some adaptations to OCD and autism treatment when it's co-occurring that are from two of the better, one's an article, one's a book chapter, two of the better sections that I like on this. So Monica Wu has this really great, what is she in? This was a book chapter too. Yeah. So Monica Wu had this great book chapter about the co-occurring OCD and autism. I encourage everyone to read it because I think she's done a really excellent job of laying out the ego-dystonic versus regulatory difference in functional assessment in nice academic language. So I encourage everyone who's interested to go check out that reference. But as it gets further into the chapter, it goes back to some of these misunderstandings about autism, where this needs to be brushed up with a neurodiversity perspective, even though the functional assessment is like spot on and it's good work. So this quote from it is, I put the bullet points in, but this otherwise is a direct quote from the article. Personalized CBT utilizes in vivo exposure, ERP for compulsions within the context of OCD, within ASD-specific modifications such as more concrete. We're talking about concrete language. Simplified cognitive techniques, visual aids, social stories, greater inclusion of parent-teacher for generalization, and inclusion of behavioral reward program throughout the treatment. You know what I read in this? Conflating autism for low intellectual ability. 30% of autistic folks through the current diagnostic epidemiological way of doing this sort of research, 30% of folks who qualify for an autism diagnosis have intellectual disability. And then we get this blending of categories here that is not my experience with folks with autism. But certainly, there are folks who are severely disabled who absolutely need accommodations that are related to their IQ and their autism, or related to their developmental level, their language preferences, and their autism. But it's not inherently autism, because the autistic folks I know use sarcasm really well, talk in metaphor really well, do great creative writing, use their imaginations in amazing ways. You can think of an autistic person who writes fan fiction and has developed amazing characters and plots. Is this a concrete thinker? This is someone who's thinking about all these magical ideas using metaphor and fluffy language in their writing. It doesn't feel so concrete. The right answer should be not think concrete. It should be learn what artistic communication looks like. I guess that's on a later slide too. And simplified cognitive techniques. A lot of the autistic folks I know are really complicated. They're too much. They're too much for their providers. They're too much for their families. They see the world with such deep complexity, and they're so unsatisfied with these cursory, hand-waving, oh, it's just this way kind of explanations. So simplified cognitive techniques, that doesn't feel right for me either. Visual aids. Some people are really visual. Not everyone is. That one's a little bit nicer. Social stories. I actually really like social stories. I think that's a great example. It's a way of learning that can use strengths in autistic people's processing to ingrain stories. And the way that we write the stories can be, again, bespoke to what that individual is trying to do in their environment, and does not need to include any pathologizing language in it. And then when I get to greater inclusion of parent and teachers, I hear coercion. It's just impossible not to hear coercion. One way you can hear support, but if we don't call this anti-coercive, we don't make that explicitly in there, then we don't draw the line between support and coercion. And then the inclusion of behavioral rewards programs throughout treatment. Again, are we restricting access to identity and needed regulatory stimuli so that the person performs the behavior that we expect of them and they only get it after that? That's not okay. But are we giving them a special reward that they can earn and they chose, and that they're not restricted in what they need to regulate? They're not losing their identity or sense of self, and they can still earn a reward? Well, it probably takes a little bit of intrinsic motivation to do it. It takes away from intrinsic motivation when people learn to do things for rewards, but it's not entirely bad. But there's a big difference between, I use my tablet every night when I'm calming down from how stressful my evening swim practice is, where it's so loud and so much of a sensory nightmare. And then a parent saying, no, you can't use this until you've done all these executive function tasks about cleaning and all the stuff that we've got to do for your chores around the house. And the person is going to sleep or trying to go to sleep, highly dysregulated, crying themselves to sleep, like unable to find any way to regulate. There's a big difference between that and the person who says, if I do 100 exposures, I get to go to Disneyland, right? There's a big difference between what you need and the really shiny thing that we could get through rewards. The analogy that I like to use is, when we're taking basic behaviorism classes in undergrad, or some of us even in high school, a lot of us learn how to train rats to press a lever. And you put the rat in the cage with nothing but the lever. And if you want that rat to press the lever, the first thing you have to do is starve the rat. Because if there's a pile of food in the middle of the cage, it puts its nose right in there. It doesn't go sniffing around for, what is this behavior that I've never thought of before that I could do to try to get some food? I'm not okay with starving people to get them to perform the behavior the way we want. That is by definition coercive. But if there's a pile of food in the middle of the cage and we can communicate with the rat and teach it, if you push the lever 100 times, you get a chocolate donut that's way better than rat pellets, then it's not the same thing. And I'm okay with this one. Yeah. Okay, so another book chapter here has a bit about transdiagnostic approaches to treating OCD and autism together. I guess it was actually transdiagnostic approaches to anxiety and autism, if I'm remembering correctly. But there's a nifty acronym in here that I just love. It's this PRECISE acronym. So the P is collaborative partnership. The R is right developmental level. The E is empathy for your client. The C, creativity and approach. The I, investigation, experimentation, as opposed to just being the expert. And S, self-discovery, what they already know. And E, it has to be enjoyable. It should be fun. Cool. Okay, so I'm picturing, like, I got a daughter in preschool, and when they clean up, they're going to sing the cleanup song, stuff like that. I'm picturing some bringing creativity and play and joy into the treatment work that we do. But then this same book chapter goes on to say some things that I say, I think you need to brush up on what it means to be affirming in this. So this is an example of, in the bottom right-hand corner here, this card with a rocket ship with Ethan's name on it. This is not a real Ethan, it's from the book chapter. It's got his command. I can't read it because it's under everybody's faces, but say friendly words or keep your mouth shut or something, keep quiet, keep to yourself. And it's got a picture of a rocket ship on there because it's special interest. So now here we're saying, Ethan said he likes rocket ships. Ethan said he gets in trouble the most for talking when he's not supposed to. And so we've got this coping card for them. But where did we say, hey, Ethan, find people who will be loud with you? Where do we say, Ethan, when you go play basketball with your friends and you're shouting, that's a real strength of yours. Everyone knows how to, when to pass you the ball. Everyone has a better time because your energy is so high. Instead, what we're saying is, to fit in, to make this classroom work better, you have to do this. And so we're going to give you little reinforcement, little treats about your preferred stuff along the way. It won't be so bad that you have to do exactly what we say. Again, I want Ethan to learn that you can go to your friend's birthday party where you might have been excluded because you learned this skill of saying friendly words instead of being mean. But if that's supposed to be your socialization, you're going to have a hard time because you're going to keep messing up. You're going to keep saying stuff that's a little bit too harsh. And you get around people who will roast alongside you. Get along with people who've got a high tolerance for this sort of back and forth that's a little bit more argumentative. Missing that piece, it's not neurodiversity affirming. It's not just about get the person to do normal behaviors, but be less coercive about it. There's two sides to it. So we come down to, if I'm saying these are still problems, can we even reconcile the history of behaviorism with the neurodiversity affirming lens? And this is going to come a lot out of neurodivergent folks' problems with applied behavioral analysis that is really like the original roots were those coercive and the change who you are, and we're going to help people become more human. Then as ABA grew up, we got rid of all that pejorative stuff, but the history of it still seems to suggest that it's grounded in a root of, if you do this therapy, it's going to fundamentally change who you are, and then life will be easy because you'll be normal. And I don't want to tell anyone that normal is a good thing. So is that still in ABA? Hey, it depends who you ask. That's the truth. But because it is in the historical underpinnings, like with full certainty, we're going to see this community response to behaviorism overall. And so can we reconcile? I had some graphics in there that I guess don't translate to the full screen, but I say yes. So neurodiversity is by definition heterogeneous. And I don't want to see neurodivergent folks get guardrailed away from access to care that they could potentially benefit from. Not everyone's going to respond well to behaviorism. I'll stick with that. But I still say it's the most powerful tool. I want people to entertain the thought at the very least before they go in other directions. let's not be part of guardrailing people away from access, just as much as we are not forcing them down. Well, you just didn't try hard enough. There's a secret compulsion that I didn't know about. Let's be careful of both of those dimensions. And then also, yes, we can reconcile this history because not all of the therapies, not all of the ESTs are steeped in coercion. Many behavioral therapists are also neurodivergent themselves, and they're sensitive to this. And even if you are neurodivergent yourself, you still have to do the work. You still have to undo internalized ableism as part of this. So there's a lot of therapists that would identify more as neurotypical who have done the work. And we get into a relationship with a provider who makes a treatment plan with us. And there are a lot of good providers that know how to use these tools without snapping back to that nomothetic approach. And then I will also just add, even though I say yes and yes, I can also add behaviorism is not the only way. There's also inference-based cognitive behavioral therapy is an evidence-based approach for OCD. It's not cleared the Division 12 of the APA criteria to be considered an empirically supported treatment. But in 2015, there were some new guidelines that came out about what makes an empirically supported treatment. And guess what? ERP got bumped back from very strong support back to just strong support, according to those guidelines, according to the reviews that have been done. There are really intense guidelines to be met to be considered an empirically supported treatment. And ICBT is on the way. We've got the non-inferiority trial underway and just waiting on all the data to come back so that can all be published. When that's all published, it'll be included in a meta-analysis. And then I think we meet criteria to be considered an EST if that's the direction that the group wants to go. So there's always inference-based CBT. There's also metacognitive therapy for OCD, mindfulness-based cognitive therapy for OCD. That's an OCD-specific mindfulness-based cognitive therapy. General mindfulness training is helpful for a lot of folks. Trauma therapy is helpful for a lot of folks. These are not OCD-specific things, but maybe I don't have something that fixes your OCD right off the bat, and I want to build some hope just through some of these other strategies. And then we see a lot of popularity in the neurodivergent community for internal family systems. Seems to really speak to the experience of neurodivergent people in a lot of cases. And I think Melissa Mose might be in this talk. I know she's done some really excellent work here. So go check out some of her talks because she's really brilliant in this. I hope she gets involved and gives us some more language to use and how to bring this into the OCD world, because that's really more designed for a trauma therapy. It is definitely not our empirically supported treatment on the horizon. It is speaking to the preferences of individuals. It's making a idiographic conceptualization and a treatment plan according to the preferences of our clients with full informed consent. So I'd like to see all these models get brought in. So what are my suggestions? How do you make a neurodiversity affirming practice? You value autistic communication, this honesty, specificity, dumping. I just talk for 2 hours straight without really catching my breath. If your client comes in with something like that, one person's idea might be, let's make a visual schedule where for the first 10 minutes, we're going to talk about homework. And then for 30 minutes, we're going to do intervention. And then for 10 minutes, you can info dump on a topic of your choice. I do a lot better with 2 or 3 hour therapy sessions and I'll pay for it. So let's do that. I can't get an idea out in an hour. And the idea of you would cram all of this into 10 minutes of my interest spread out over many weeks just it's pretty aggravating. So don't let your therapy clients be too much for you. Value their communication, value how it might rock you back on your heels at sometimes when folks are being more confrontational, or when folks are being more specific, or when folks are saying, I need to know something that you don't have an answer to, and I'm upset that we don't have an answer. And it's not something where it's just uncertainty, it's something where you're not an expert in all things. We have to value that they're bringing something really positive to the table with these communication styles as well. Next suggestion. Like negotiation and accommodation are like dirty words in the OCD community, but so many of these things are not going to fully habituate. And really, we're asking people to push their disability under the social model into invisibility and just hide it from everybody else. So we need to teach clients as well as the systems that they're part of to be good at negotiation so they can reduce accommodations where it's appropriate and not where it's not going to be appropriate. And we can maintain relationships. As we say, there's a diversity of cognition and processing happening here, and all parties have to be okay with it. It doesn't snap to the neuronormative opinion. It doesn't snap to the autistic opinion either. Another one is reassurance. I've been talking about self-invalidation all evening. So these folks often need a ton of reassurance, and it might sound the same as you've given them reassurance before. It's not a dirty word. Get into what is the function of this and give folks reassurance where we're not making their OCD worse with it, and think harder about this stuff. And then finally, this behaviorism needs to expand to some counseling practices too. We know these common factors practices matter some, and building an identity just feels so crucial for folks who have been self-invalidating, for people who are invalidated in many ways. We see with the Black community that Black folks could be at risk of developing OCD due to minority stress, and that developing a Black ethnic identity model is protective against developing OCD. But what happens when we build a strong sense of identity? I believe it's a valuable tool to be protective against psychopathology of all kinds and to be resilient against stressors as they come to us. That work should feel like super empowering, liberatory. It should put a smile on your face, or maybe a scowl on your face sometimes, where you're like righteously indignant, but that should be valued in the therapy room too. Getting through those big reactions can let us be a lot more open to conversation because we've built trust down the line. And then we might see some flexibility come when we've given them agency to say, this is who I am, and I'm mad as hell that everybody's tried to change that. So what do I want to do with this? I want to encourage everybody who might be here. I want to encourage everybody who might watch this on YouTube. I want to encourage everybody who talks with me. If you think you got something to say, I think you do. I've heard so many brilliant voices from this community. I mean, I'm neurodivergent. I think neurodivergent people are my people. I've heard brilliant neurodivergent people say things that they are maybe feeling not quite ready to say in big rooms with an audience who's not familiar with this material already. And what I want to say is, you've got something valuable to say. I'm going to back you. I'm going to promote your materials. And you don't need to be 100% right. I'm not 100% right here. You know who else is not 100% right? Any of the journal articles that I cite. Any of the scientific advisory committee of our favorite organizations. No one is 100% right. The science of the field turns over every 7 years or so. At least that's what I had to say when I did my comps for my doctoral program. Don't hold yourself to a standard that the guy in the ivory tower is not holding himself to. And I'll be even a little bit more direct. Don't let a mediocre white man hold on to that microphone and make money with his silliness, where you are smarter, you have lived experience, you have a more powerful thing to say, you are more prepared, you put in more effort, you honored more complexity. Don't let those people dominate the conversation. So these are some of the ideas of some of the trainings I want people to build. I don't know. I'll build some of these. I've done OCD as neurodiversity, kind of working on packaging that up still. I really want to work on selecting intervention for OCD based on client phenomenology. That's sort of like a project that I'm going to do. But I want to see people do universal design for ERP. I don't hold all the knowledge for that. We all hold the knowledge for that. I want to see rewriting of these co-occurring condition discussions that bring in all this stuff that I'm talking about today about, OCD as neurodiversity, as well as honoring and valuing individual difference as opposed to fundamentally changing self. And, I want to see people do these talks about nice white lady energy is not a standard of care. I want to see people do a talk about loving your OCD part. Boss back the OCD bully. You got a monster that you have to fight with. There's a war that we're winning territory against, one battle at a time. Works for some people, but if you see yourself as having a lot of parts, I'm not sure that this fits with my model so well. I want to see some people talk about how to love your OCD, not be so angry with it, because it's internal. So in summary, diagnosis is more useful for medical coding than it is for conceptualization. The idiographic is superior to the nomothetic when we can get down to functional. Lots of harm has been done by knowledgeable clinicians with lazy conceptualization, and we are far too cavalier about that as a profession, and the mental health client community is noticing. Grassroots content creation and dissemination of neurodiversity-affirming content across broad swaths of the professional community is how this movement will hit its tipping point. So 2 hours pretty much on the nose. Thank you guys for letting me dump and listening to all this content. And that's all.